Hi, I'm Tom Buchholz. I'm a radiation oncologist who practices at Scripps MD Anderson Cancer Center in San Diego. I'm also the medical director of Scripps MD Anderson Cancer Program. It is clear that many patients benefit from the receipt of post-mastectomy radiation. Specifically, randomized trials for patients with positive lymph node have indicated that post-mastectomy radiation can improve local regional recurrence, and in doing so, actually can improve overall survival. This benefits in addition to those seen with the systemic treatments. So the combination of mastectomy, systemic treatments, and radiation is a standard of care for many women with positive lymph nodes. The question today really is one of the most favorable category of lymph node positive disease, and really addresses the question, does every single patient with a positive lymph node require post-mastectomy radiation? This continues to be an area of controversy. My personal opinion is there is a subcategory of patients with positive lymph nodes who are safely treated with mastectomy and systemic treatments without radiation. If you're going to define the risk parameters, clearly the number of positive lymph nodes are important. In this example, there's only one positive lymph node. The second parameter is the biologic subtype of the disease, with patients having estrogen receptor positive disease doing more favorable than those with triple negative disease. Thirdly, the size of the primary tumor is likewise an important consideration. Again, in this hypothetical case example, we're dealing with someone with a T1 tumor, so this clearly is the smallest component of tumor. And finally, the completion of the surgical procedure. Did this patient have a complete axillary lymph node dissection, or was it just a positive lymph node in the setting of a sentinel lymph node surgery? Because we know that people with positive sentinel lymph nodes can have additional positive nodes, and if those aren't dissected as a component of axillary lymph node dissection, then this too is another consideration as to whether they need post-mastectomy radiation. So as a practitioner, when I look at a patient like this, I'm trying to define whether this is a favorable category in which we could potentially forego the potential toxicities of radiation. And again, the parameters I look at is the number of positive lymph nodes, the size of the tumor, the type of axillary surgery that was performed, the surgical margin status, the age of the patient, the presence or absence of lymphovascular space invasion, and the presence or absence of extracapsular lymph node extension of the disease. So presumably in this, it falls into the favorable category of patients with 1 to 3 positive lymph nodes. I've done a research study, for example, that looks at people with 1 to 3 positive lymph nodes with very favorable disease characteristics treated with mastectomy and systemic treatments. And we found that if you had ER positive disease, you had fewer than 4 positive lymph nodes, if you had an axillary dissection, if you presented with clinical negative axilla and only found to have positive lymph nodes at the time of the surgery, and if you were postmenopausal, those patients had very, very low risk of local regional recurrence, even if radiation was not given. And when we did radiation in selective circumstances, it didn't really seem to be of benefit. So there are cohorts of patients, I believe, who have 1 to 3 positive lymph nodes that can be safely treated with omission of radiation. Although this is still the subject of ongoing randomized trials. There is now an ongoing trial looking at people with 1 to 3 positive lymph nodes who have favorable biologic characteristics like ER positive disease. This trial is even going further and studying what's called an oncotype, or molecular profiling of the disease, with a gene expression that's commonly used to determine whether to give chemotherapy or not. With this oncotype 2, if it has a favorable score, those patients are randomized to not receive post-mastectomy radiation or regional lymph node irradiation. But outside the context of the clinical trial, at least based on a lot of data which suggests that if you had 1 to 3 positive lymph nodes and those favorable biology characteristics, age characteristics, favorable tumor size, I think those people have close to 95% chance of local regional cure with just the mastectomy and systemic treatments. And often I discuss with them the risks and benefits of radiation, but we elect to decide not to treat those patients. So again, just to summarize, clearly everybody with 4 or more positive lymph nodes. I get concerned if they have 1 to 3 positive lymph nodes without an axillary dissection, which is not, that's an increasingly common scenario now. And then I also consider patient age, lymphovascular space invasion, extranodal extension, and other high-risk features that would be unusual. But that all being said, ER positive is the most common type of breast cancer, and it's much more common to have 1 to 3 positive lymph nodes than it is to have 4 or more positive lymph nodes. So despite us picking a favorable subcategory, it represents a significant number of patients. And if we could avoid the potential toxicities of radiation in that cohort, that would be obviously in their best interest and in the interest of breast cancer care in general.